My thanks to Sang and Kyle for asking me to speak here. The title that I've been assigned is Squamous Anal Dysplasia with or without HIV. Really breaks down into three parts, and we'll cover all of them. Office surveillance, HRA, which is the hotspot, or is there something else that we can do? Anal cancer, just general statistic, we always start with that. Really, a relatively small component of the cancer care that we give. There's only about 1.5, maybe close to 2 per 100,000 year lives of patients. So it's a relatively rare cancer. We cure most of them, and really less than 0.5% of the cancer care we give is to anal cancer. So it's not a very, very large topic until you start looking at subsets of the population. So if you look at the general population, it's a little less than 2 per 100,000 person year lives. But if you look at the HIV negative MSMs, men who have sex with men, it actually will double or triple, depending on what numbers you look at. If you're looking at solid organ transplant, it goes up to about 10 to 15. And then it's highest and most striking in the HIV positive men who have sex with men, where it rises to almost 50 or 25 times that of the general population. And just for comparison's sake, if you look at the same number for colon cancer in our general population, you're actually more likely to get anal cancer if you're an HIV positive man than you are to get colon cancer in the general population. So to answer the first part of the question, HIV positive or negative, I think the answer is there's no role for screening in the general population. It's a pretty rare cancer. But if you look at the subtypes, certainly in HIV positive MSMs, and then also if you look at people who are immunocompromised or organ transplant or something like that, it may be worth looking at. This is just one algorithm put out by Palevsky up in San Francisco, where he does include HIV negative men in his algorithm for monitoring of dysplasia. So general population, probably not. Certain subpopulation, extremely important to monitor this pathology. Looking at HIV in general, just really briefly, the rates of HIV new infections globally have gone down quite a bit since 1996 when they peaked. The death rates have also come back down quite a bit also, whether that's due to the symbiosis of this pathogen with the population, all infections tend to learn to live with us rather than kill us, or whether it's due to care. In any case, the length of survival has gone quite a bit. So if you look at the number of people that are living with HIV, it is rising pretty rapidly, and there's more and more HIV-infected patients throughout the world. Some people are surprised by this statistic, but if you look at the life expectancy of people with HIV, this is from UK, but there's similar data from our neck of the woods also. If you look at the life expectancy, if you're a healthy HIV patient, T-cell counts greater than 200, your life expectancy really mirrors that of the general population. If you have low T-cells, if you're sick with HIV, you lag about 10 years behind. So really, HIV has become a survivable disease, and life expectancy really is starting to mirror the general population if you can control the disease well. So why is that important to the subject we're talking about today? Well, because there's a lot of data like